All good.
And we're live. All right, brilliant. Now, hello everybody. Thanks for joining us. We're coming live again tonight, and our subject is Femoroacetabular Impingement. Bit of a mouthful, or FAI for short. Hip impingement is the subject that we'll be talking about tonight. I'm coming live from the Physio channel studio tonight, and the reason I'm doing that is because later on I'll be able to show you some movements and some practical elements as well. And the camera is separate from the laptop, so that's a bit odd, because when I look at the laptop to see Mike, I just need to realise that I'm not looking at the camera. So I'm looking at you right now through the camera. If I seem to be looking away at some point, that's because I haven't quite got used to the technology setup. Now, I'd like to introduce Mike Grice, who most of you have listened to over our previous sessions. Those of you who don't know him, Mike Grice is an osteopath and he runs movement therapy education. And Mike's going to introduce our topic tonight and talk about the anatomy of femoroacetabular impingement. So over to you, Mike.
Thanks, Dan. Thank you. So as well as being an osteopath, if you have listened to some of the stuff I've talked about before, I'm also an anatomist. So I spent a couple of years in my postgrad studies doing dissection work. So I love anatomy, bit of an anatomy geek. And yeah, I was really pleased to be able to do a bit of anatomy today. So we're going to have a look at the coxal joint, the hip joint, in a bit more detail. Apologies if you are very experienced in anatomy and this is nothing new to you, but I'm going to kind of start from the beginning and then layer it through. So yeah, if it is going over old ground, then I do apologize. Okay, so we've got Rebecca has got no sound. I just want to, if you pop in the chat box just to make sure that everybody else has sound, if you could give us a thumbs up just to make sure we're all good, that would be great. Yeah, I think a couple of you are having problems with your own private connections by the look. I think everybody else is okay. Good. Okay, right. So we'll crack on. If at any point the sound goes or the vision goes, then we do record these lectures and they're put on the Physio channel so that you can watch them back again. So don't worry about that. Okay. So yeah, the hip joint, coxal joint is, as you guys know, if you are a therapist or work in health and fitness, then it's a synovial ball and socket joint, and the socket part being on the pelvis, and then the ball being the femoral head. So gonna have a look at the insides of that hip joint in a bit more detail, and the reasons why we would get an FAI, a femoroacetabular impingement. So the hip is the articulation or the join between the head of the femur and the acetabulum. The acetabulum is the socket part. Okay, so that's the socket area that the femoral head will fit into. As you can see on the picture there, although it's a bit of a cartoon picture, it's not really like that in real life. The ligaments are all just one big mesh. They kind of make up the capsule of the hip joint. And you've got the iliofemoral ligament going from the ilium to the femur, pubofemoral from the pubis to the femur, and then ischiofemoral from the ischium to the femur. And they all encapsulate around that hip joint to get it very, very solid, robust joint. So what we're going to do is kind of strip that layer of ligaments away and look a little bit deeper into the socket. So in the socket, the acetabulum area of the pelvis, you have something called the labrum, and the labrum is a cartilaginous structure, and what it does is it helps to deepen the acetabulum, the socket itself. So I'll show you a couple of videos in a sec that shows you just how powerful the structure of that hip socket is. It's absolutely crazy how much force you need to be able to separate those when there's no muscles and ligaments all around them. So the labrum is continuous with something called the transverse acetabular ligament, and that surrounds the whole surface of the acetabulum. And again, I'll show you a little video in a second so you can see it for real. So the labrum and the transverse acetabular ligament encompass more than half of the femoral head. So it comes out and it kind of covers that femoral head, and it's an extension of the bony structures of the socket, which is the acetabulum. This is really key for the bit that Dan's going to do in a second. So the labrum is different from the front to the back, so the structure is different. The attachments of the collagen fibers of the labrum to the acetabulum differs anterior posteriorly, so front to back, and the anterior fibers are parallel to the bony edge, and that makes it vulnerable to the kind of injuries that we're going to be talking about today. If you have changes within the acetabulum itself or the femoral head, then that can disrupt particularly that part of the labrum. Okay, the labrum itself and the ligament that surrounds it, so it's continuous with it, create a really tight seal around that femoral head, and you get a negative pressure that, as you'll see in a second, it takes quite some force to be able to pull that femur from the acetabulum, from the socket. Okay, so I'm just going to show you this video here. So this is available on YouTube. This is an Ackland video if you're interested. So this is just a snippet of the video here. So this is the articular surface of the acetabulum. And what it will show is it will be show the soft tissue layers being added to this video in a sec. And there's the head of the femur, there's the neck of the femur, and this is important for later when we look at deformities of this area and what can happen. And then obviously they articulate with each other, and you've got a lot of movement available in the hip. Obviously not as much as the shoulder. But here we go. Now, so the femur has been taken away. I'll just pause that there. And the yellow ring that you can see all around this opening here, that's the labrum. Okay. And if I just rewind it just a second, you can see it as a complete unit. I'll just take that off there. Okay, so you'll be able to see it as a complete unit, and then they'll take that away. There you go. So there's the capsule. Take away the capsule, and there's the labrum underneath. So you can see that labrum lines the acetabulum all the way around, and then there's a little ligament just on the inside of that. A fossa is a dip or a shallow. And there's a little ligament in that dip area that attaches onto the head of the femur. So this little projection here, you've got the ligamentum teres, and then that attaches onto the head of the femur just there. Okay, so that's been described, that ligament, as like the ACL of the hip. Okay, it's a very, very strong ligamentous structure that aids in the stability of the hip joint. Just going to show you another little video here. So this will show you the suction power, the negative pressure power. So this is the labrum and the femoral head in the socket, and they're trying to distract that. I'll just play it again for you there. They're trying to distract that femoral head from the acetabulum. Okay, so pulling it laterally, and you can see the amount of force it takes before the femoral head actually comes out of the socket there. So it's under immense negative pressure there. Okay. So things to be aware of is there is a lot of variability of anatomy within the hip. Okay, and this can predispose people to injury, which is what Dan's going to cover in a second. So it's worth being mindful of the kind of differences that there are. So the actual neck of the femur can be naturally just at different angles, and I've shown you a couple of pictures there. On the right hand side, some actual cadaveric specimens, and then on the left a picture to demonstrate it. So you can have a coxavara position where the angle is less than normal, in inverted commas, and you may have what we would determine a knock-kneed position at the knee. Okay, so we can have a varus at the hip, and then a valgus at the knee, and then the other way around, we can be bow-legged at the knee, so we can have a varus knee, but a valgus hip. Okay, so and that's just because of the angle of inclination. As the femoral head attaches up into the acetabulum, the angle of the femoral neck may differ. Okay, so that will give you a different look of how that person moves and how that and how they will respond, and also their likelihood of injury within this area. Okay. You've also got something called femoral version. So this is the angle at which the femoral head sits in the acetabulum again. But normally your femoral neck sits slightly forward, so slightly antiverted, we call that. So about a 10-15 degree antiversion, and that's considered to be, well, between 10 and 20 a normal range. If you have an antiverted hip, and Dan's done a video on this on his Physio channel looking at something called Craig's test, you can do, if the patient was to centralize the position of the femoral head within the acetabulum for comfort, then their feet would be in a naturally toe-in position. Okay, so, and that's just normal for them because of the shape of their hip joint. And then you can have retro. Okay, so retro going back, and that's how I remember that. So got a retro picture there. So we got a retroverted hip as well, and because of the centration of that joint and the comfortable position that would be in for that patient, they would have a naturally toe out position. Okay, so we've got, and there are other anomalies as well. So you can have torsions through the femur, different depths of sockets, and all of these things may make you more susceptible to these kind of injuries that we're going to be talking about today. So one of the things that Dan's going to have a chat to you about is something called a cam impingement. And a cam impingement is where there is a deformity on the femoral neck. Okay, so where the femoral head is, just off of that to the side, if there is a deformity on that part of the neck, then that means there may be an impingement as you're rotating the femoral head around in the acetabulum. There's a likelihood that it will catch the labrum, okay, because of that deformity on the femoral neck. So there's an aspherical shape of the femoral head, so it's and that's why it's called a cam. So it's not a circular shape, it's slightly oval, and that's why it catches. Okay, so that'll be a cam impingement. So the bony prominence of the non-spherical portion of the femoral head glides under the labrum. All right, and remember that portion of the labrum is slightly different to the posterior aspect, so it's more likely to become injured in that particular area. And then we have a pincer. So a pincer impingement is to do with the acetabular side. So this is the socket side. So the cam is to do with the femur, and the pincer is to do with the acetabulum. And this is where there's an increase in bony projection or a deeper socket, which means that the acetabulum covers more of the femoral head than it should, and then it crushes the labrum against the side of the femoral head. Okay, so you can have either a cam lesion or you can have a pincer lesion or pincer impingement. Okay, and that's a bit of a summary there. So I'm going to pass you over to Dan. He's going to have a look at the assessment of the hip and some treatment for it as well. So I'll pass over to you, Dan.
All right, nice one. Thanks, Mike. Let's get my capture over here. So there we are on the screen. Nice one. Okay. So in clinic, the key symptom that the patient would present with is anterior groin pain, or groin pain in general, but anterior groin pain. It's thought that generally in the literature and from clinical experience that the absence of the anterior groin pain would lead you to think that it's probably not a femoroacetabular impingement issue. So it's the anterior groin pain is that key symptom that you're looking for. And that often occurs when they are doing certain activities. And those are activities, of course, that involve a lot of hip flexion, hip adduction, or also internal rotation. And the pain usually comes on for a reason. They're probably doing some unaccustomed activity. The classic examples that I see are people who have started doing some more squats as part of an exercise routine. So if people are doing some home workouts, maybe it's Joe Wicks or something, and they're doing lots of squats, particularly with the legs into more of an adducted position, going down into deep depth squats or as de grace type deep squats. If they're doing those repetitively in an unaccustomed way and with added weight, then that could be a factor which triggers symptoms of impingement, whereas previously there wasn't enough injurious volume in order to cause enough symptoms for them to present, basically. The other ones are cycling. So I'm going to pull the bike out in a moment and show you that. But as you can imagine, on the bike, you've got a lot of hip flexion, depending on what type of bike you ride and how low and aerodynamic you're getting. If you keep repeating that hip flexion, then again, you're building up that enough volume of repetition to start to trigger some nociception, some pain from that area. Because typically there has to be something which has triggered it. Otherwise, it would have been present from a very, very young age. Sometimes in clinic, I find it does creep up on people, but often they started doing something which has made it rear its head and present. The other movements, less sports related, are if you combine flexion with adduction and internal rotation. So it's that kind of flexing and twisting, internally rotating over a hip. So if somebody was doing that as a kind of, I don't know, picking stuff up the floor, keeping the weight off one leg and always flexing and internally rotating over the other leg, then as you can see, you've got that impingement type mechanism. It's that combination of flexion, adduction, internal rotation, which we'll use for assessment in a moment. Sometimes it can be leg press in the gym, Marcus. Yeah, absolutely. You know, leg press in the gym, you really do get a lot of hip flexion. Plus, you've got the weight pushing the hips back as well. So it's certainly something which can cause that irritation. Sitting, it could just be sitting. I read a case study of a pilot who would have symptoms that would start to come on after a period of time. And no matter what he did, he couldn't get comfortable in the aeroplane. And the symptoms wouldn't come on, you know, within a few minutes. They'd come on typically, say, an hour or something. But he ended up needing surgery because he just could not sit for any longer than an hour without the symptoms coming on and worsening. So there we've got a very low level irritation, which builds up over time. And I should imagine in his case, there was a very pure anatomical cause to his pain. And I'll expand upon that point in a moment. So, assessment. Let me bring the couch out here so you can see me in view. There we go. There we go. Do you like my pillow, guys? This is where I sleep out here. Gives me a break from the family and kids. There we go. Oh, yeah, sorry. Right, forgot. What we're doing, hip flexion. Now, the hip should flex somewhere, well, it should get over 115 degrees, okay, on a nice healthy hip. But it's very variable. If you've pushed a few hips, you'll know that it's very variable how much flexion they get. The key thing you're looking for is the end feel. The end feel should be soft, okay, should be a soft end feel to hip flexion. If there is a hard end feel, it suggests that there's some kind of bony buttressing going on, and particularly if you get to around 90 degrees and then there's a bit of a block, you know that it's the hip and it's not tight glutes, and you know that stretching is not a good idea because it will not be stretching. And as I say to patients, Stretching is good if they feel stretching in their glutes, but squashing is not. So if they're doing this in the hope that they'll increase their flexibility and all they're feeling is squashing in their groin, then they're doing themselves more harm than good. So hip flexion, is there a hard block to hip flexion? Is there restricted range to hip flexion as well? Internal rotation, okay? With internal rotation, we should see somewhere in the region of 35 to 45 degrees, apparently, but a lot of the time I find there's a lot less than that. But if hip internal rotation is very limited, and again, there's a bony block towards the end of it, then it indicates that there may be some restrictions to the movement here. We may not have found any symptoms yet, guys. All we may have found is restricted motion and hard end feels, all right? Now, that brings me on to the first test, which is the FADIAS test, sometimes called the FAIR test. And it's one of those acronyms. It stands for flexion, adduction, and internal rotation. So flexion, adduction, internal rotation. Normally you do this on a patient, but of course tonight I mentioned we'd be doing some assessment as if you were doing a remote assessment. So you literally have the patient at home doing this, flexing their hip, bringing it across their body, internally rotating, and then pulling the hip towards the opposite shoulder, okay? So holding around, pulling my hip towards the opposite shoulder. What I'm doing there is I'm squashing my groin, and I'm actually causing an impingement type mechanism. Even in the absence of a cam or a pincer, we're going to get some form of natural impingement going on there when we do this. So when you do this to people, when you do this with patients, try this, or if you try this on yourselves right now, you might find that it's uncomfortable. And I can report now that this is uncomfortable. I haven't got impingement, but I can feel that I'm kind of giving myself impingement by doing this movement here. Right, so that's the FADIA test, or the FAIR test. But that doesn't determine whether or not I've got femoroacetabular impingement. In fact, that test has quite a low specificity. We talked about that, I think it was last week, I can't remember, or the week before. But if the test has low specificity, we had that mnemonic spin. So if it's low specificity, it means you can't necessarily rule it in. Because when you do that movement, there's lots of things that could cause that to be symptomatic. You could have an arthritic hip, for example. And those two things often go together with femoroacetabular impingement. You know, other causes of groin pain as well. So that test is not very specific. So therefore, if it's a positive test, it doesn't mean that they do have femoroacetabular impingement. However, if it's a negative test, the test does have a slightly better sensitivity. So if the test is negative, then it's likely that they don't have. Therefore, you can rule out a femoroacetabular impingement. Now, I want to talk to you about triangles. Just checking. Okay, Mike, can you hear me?
Yep, can hear you, mate. Yep.
Right, so I was talking a lot, and I just wanted to make sure that everyone was still with me. As I was saying, I want to talk to you now about triangles. The first part of the triangle was that test, the flexion, adduction, internal rotation test. Okay, you do the test. If it's painful, it's a positive test. That's the first thing. The other part of the triangle we mentioned at the start, groin pain. If they have anterior groin pain, that's the two corners of the triangle. Now, the third corner of the triangle is what Mike was just looking at, and that's the results on imaging. All right. So if they have an X-ray, and on the X-ray they've identified a cam or a pincer, or most commonly both, then you've got three things. You've got positive clinical tests, you've got associated symptoms, and you've got clarification on X-ray or MRI, or you've got clarification on imaging. There's a structural situation there going on. So you need those three things to triangulate to give you the diagnosis of femoroacetabular impingement. Because you don't have impingement if the X-ray says you do, because impingement is a thing which happens and X-rays are just static pictures. The fact is, about according to research, up to 25 to 30% of people actually have a cam or pincer or both shape to their hips. So rather than call it a pathology, a problem, it should be called a morphology instead. So often healthy people without symptoms will have a cam or a pincer or both, and they don't have any symptoms. So what that means is that it's not the sole cause, and having those abnormalities doesn't mean that you're going to have symptoms. So that's the first thing to realize, is that it's a shape, it's a morphology, it's not automatically a problem. That's why you need the combination of the clinical report, the testing, and the imaging, and not just going off the imaging itself. Other tests that you could look at, there's a collection of tests on the Physio channel that Mike's already referenced, but I wanted just to show you a couple. One was very easy, and it's the log roll test. So you sit the patient down with their legs out in front of you, and you just passively, or remotely, you'd have to do it actively, of course, but you just externally rotate and internally rotate one leg followed by the other leg to look at the amount of internal and external rotation, just to see if there's any significant differences there. This is not a test for femoroacetabular impingement. This is a test for general hip function. The other general hip test that most of you would have done a lot is the Faber's test, so flexion, abduction, external rotation, also known as the 4 test, because you're kind of making a number 4, and dropping the hip out here can also give you an indication of general hip range of motion. So there are a couple of tests that I would also throw in to build up a general picture of the hip, to also look for other pathologies, because it may not just be femoroacetabular impingement. You could be dealing with osteoarthritic hips, you could be dealing with gluteal tendinopathy. So you want to have a batch of tests to help you differentiate. But the FAI test is the femoroacetabular impingement test, although it also stresses other structures and could cause pain from other things. So remember the triangle, the FAI test, that special test, the patient reporting anterior groin pain, and the imaging showing the shape changes or the morphology to the joint. Now, in terms of exercise modifications, there were some studies out in the early 2000s that suggested that physiotherapy didn't really have a role for femoroacetabular impingement. However, since then, it's been suggested that actually it does, and you can get some good results. And I found in clinic that that's also true. We've just talked about how many patients can, how asymptomatic people may already have this shape change to the hip. So therefore, it's not all about the cam and the pincer. It may also be about the strength, the muscular control, the motor control around the hip and around the core region of the body. In particular, the deep muscles of the hip, the external rotators. So strengthening the external rotators is going to be a very good way of dealing with this condition. So here's a few things that I would go through with a patient who had this issue. Firstly, let me get my bicycle. There was a time when this was high tech. There we go. Seat height. You see a lot of people riding around on e-bikes these days, doing the work for them with their seats too low. So you need the seat at the correct height. And that should be when your heels are on the pedal, not your forefoot, when your heel is on the pedal, on the axle of the pedal, and the leg is at its lowest position, your knee should extend. So therefore, when you put the ball of the foot on the pedal axle, your knee stays slightly bent as your ankle can slightly plantar flex. So that's around the right kind of angle. So the right kind of height. You can imagine if your seat was too low, but you'd have a lot more hip flexion going on. All right. So this is one of the first things I advise people, is to make sure their seat is at the right height. Next, on a mountain bike, usually they're much more upright, but if they're on a racing bike or a bike that, a hybrid bike, for example, they may find that they are quite low down to get aerodynamic, but you can automatically see that that causes a lot more hip flexion. So they may need to just make some simple adjustments to have themselves more upright on the bike, which reduces the amount of hip flexion, which coupled with how many repetitions they'd have during a normal half an hour to an hour's bike ride would make a significant difference. So seat height and handlebar height, as well as distance, can make a difference. If they're here versus out here, it can make a big difference there. So you can make some adjustments on the bike, which can be helpful. Let me just move this way. Next, with the weights. So if they are doing their weights and they're doing some leg work, probably one of the worst movements they could do is to have the knees together and to drop right down low, or to do a lunge action where they let their hip give way and show and their front leg come into that adducted position and to lunge down like that. That would be one of the things you can see that squashes the groin. So we want to go wide into an abducted position. You want to pay attention to how low they go, all right? There's no need to go really low, because if that's what's been causing that aggravation, it really makes no sense for them to do that. So they can keep the hips at around 90 degrees, the legs wider, and still get a really good workout. Important to strengthen up around the hips, but to avoid going into those positions that can cause the impingement. And making those modifications can be very significant for patients, because if they've been dropping down into deep squats again and again and again, and they're causing some impingement symptoms, they might feel that that's caused a problem. Therefore, they'll just stop doing their lower body weights. They'll stop doing the leg press, stop doing the squats, stop doing the important lower body strengthening. However, they can absolutely continue and even work harder, just with some modifications and some awareness of the types of things that will help, because this will help, and the types of things that may aggravate, which is dropping right down into those positions there. So I know in the fitness industry, there's a lot of motivation to get full ranges of motion and ass to grass and everything like that. But that's not for everybody. And it's important to identify those people who are getting symptoms from that. And also, if that's done with too much repetition or done without control, then that can also cause problems for people as well. So it's important to control the movements and to have an awareness. One great exercise that we could add to that one is the abduction one, the crab walk, the abduction squat. I'm sure most of you know this one, but this is the kind of thing where we can go into that squat position and then work the abductors there with various drills from this position here. And there's a whole bunch of different things you can do to strengthen up the abductors of the hip. Whether you've got a side plank, all sorts of different things. So as you can imagine, speaking to a physio, the last thing we're going to do is just advise patients to rest. We're going to get them doing lots of strengthening. There was one important thing, actually. I was just wondering what there was one thing that's missing. This is important. So don't do this stretch, the hip flexor stretch. All right. Doing a bit of this is okay, but here is where the problem can occur. In a research review, in an editorial in the British Journal of Sports Medicine in 2016, they wrote about the types of muscle strengthening that could help. And they also made reference to the fact that if you contract the glutes too much, and force the hip into extension in order to try and achieve a vigorous stretch over the hip flexors there, then it can shunt the femoral head forwards in the acetabulum and put more stress on the anterior part of the labrum and cause irritation at that very point where you're getting the impingement. So although we've just talked about avoiding these flexion positions, tightening up your glutes too much and jamming your hip forwards can also be something which causes the irritation. And that's interesting to think about, because this is a common stretch. A lot of people are doing this kind of stretching here. And if it's done too vigorously, And there's also a lot of people out there overworking their glutes for Instagram rather than for function. That can be a mechanism that shunts the femoral head forward in the acetabulum. So don't go too crazy stretching the hip flexors, especially doing so whilst vigorously contracting your glutes, and overworking your glute maximus with hip extension exercises can cause an impingement mechanism, even though it's the very opposite to that flexion type of pattern. All right, in order to tell patients or educate them on what things to avoid, we want them to avoid those flexion, internal rotation, abductive positions. We talked about the low squats, and we talked about the poor controlled lunge movements. It may be possible to do some posture taping. And this was something that was mentioned in that article in the British Journal of Sports Medicine. From the knee, spiraling around here, obviously on the skin. I'm not going to expose my buttocks for you now, but you can see if we did this with a bit of tension, with the hip in external rotation, when the individual then turns the hip into internal rotation, the tape would tighten up. They'd still be able to do that movement, but with the tape tightening up, it would give them that pull feedback through the skin and make them aware of what they were doing. So if they habitually internally rotated their hips too much when they're doing day-to-day actions, the taping may create that awareness and help them to change that movement pattern on a more long-term basis. So there's some things to think about. And yeah, okay, I'll stop there, Mike. And
cool. We've got a few questions now. So Sarah Jones has asked a couple. So she's got a gymnast, suspects that she's got, or that I'm assuming he or she has an FAI, but the GP won't refer for imaging. Do you think it's necessary, or should she just monitor with doing some of the exercises that you've suggested and taking out the aggravating factors? What would your course of action be there?
The GP may not refer for imaging initially because they feel it won't change the course of treatment at the moment. That's the most common reason that GPs don't refer for imaging.
Yeah,
they feel that the patient is not a surgical candidate. So for that reason, conservative measures of the activity modification and the exercises are the best way to go about doing things. If that doesn't work, then they should be referred for imaging, and then that can inform management from there. But I think there's likely to be a certain amount of patients that have had surgery unnecessarily, when conservative measures may have settled things for them. But on balance, there's probably some patients who really need surgery, or especially at the moment, or have had surgery delayed and they've had significant discomfort from it. So hopefully conservative measures will help the young lady, and activity modification. I once had a 16-year-old golfer who was semi-pro, and his strength and conditioning coach said to me, look, he can't squat very well. He can't squat past 90 degrees. So I said, oh, no problem. I'll do some hip mobilizations and some glute stretching. But as soon as I flexed his hips to 90 degrees, clunk, both hips just dunk, they just stopped, and almost wondered if he'd had a hip replacement, but he hadn't. Basically, his hips just went to about 90, and that's as far as they went. So he didn't have impingement because he hadn't given himself impingement syndrome, but had his coach kept forcing him to try and deep squat, I'm pretty sure he would have picked up a femoroacetabular impingement issue. So by modifying his squat and by accepting the fact he wasn't going to do a deep squat, he was able to keep training and avoid any problems.
Brilliant. Yeah, I've had similar with the anteversion and retroversion of the hip as well. So where coaches have forced people to squat with their feet in a certain position, and it can even differ from side to side. So you can have one foot retroverted, one foot anteverted, and it may look strange, but it's normal for that individual. And again, they had terrible hip problems, and then as soon as you just let them squat naturally, then they were fine. It just took away that aggravating factor.
Thanks, Mike. I see there's quite a few questions coming through there, Mike. Are you?
Yeah, so we've got, there was another one from Sarah. So the stretch you mentioned before, the hip flexor stretch, and you mentioned that the femoral head will anteriorly migrate. Can you use a power band to posteriorize that femoral head so that it takes away from that impingement at the front of the acetabulum? Would you do that?
Yes, you can. I think if you identify a need to work on hip extension by doing those type of stretches, then I think you can do them. I just think you need to be aware that you're not jamming into that position and contracting the glutes vigorously. But I think you could have a go at doing that in a more moderate way and be able to avoid any issues. You'd have to monitor the symptoms, but if there was a need to do it, then you could do it in that moderate way. Yeah.
Good. There was a question too for the paper that you mentioned as well for that hip flexor stretch. So if we post that on the Physio channel, that would be great. And then Emma, another question. So client had hip arthroscopy and no rehab. Femur only goes 95 degrees now and feels soft end range, but feels squashed in the groin. Do you think something can be done, as he feels really restricted, but short muscle doesn't appear to be the issue? Is it just how he will be due to surgery, so scar tissue, for example? So he's had a hip arthroscopy and no rehab.
Yeah, I mean, if there's a squashing in the groin, then that's the fact. It's the squashing, stretching's good, squashing's not. So it's likely that the joint and the tissues are meeting their end range at that point. So modifications of the exercise by trying to have more abduction, turning the hips out more external rotation during strengthening exercises should hopefully reduce that. And also in the paper I read, it made reference to strength and conditioning for the hip, reducing inflammation in the hip. And of course, we know that, regular strength and conditioning is certainly a good idea in terms of pain reduction as well, as long as it's not done in that aggravating way. So you may get some results from doing that.
But a nice statement rather than a question from Peter. Said, over the course of the webinars, you've destroyed my postural assessment education.
I hope that wasn't with movement therapy education.
Yeah, sorry about no. Yeah, I've never met him.
No, sure. Yeah.
This is a good one. What about running with FAI?
Yeah. So it's not a problem, but it's not a problem. It's not a cause. However, if you've irritated the anterior hip and the labrum, then sometimes the hip extension motion of running can pull on those structures. And if they've been sensitized, if the nociceptors at those areas have been sensitized, then you may get some irritation from that. But the running motion shouldn't bring it on. But if it's been sensitized, it may be irritated by the hip extension motion of running. So that's from my experience, that's what can happen.
But would you just try to change their cadence whilst they're symptomatic? Is that how you would modify that?
That they may have been doing something prior that caused the anterior groin irritation. So they may have been doing some extra strength and conditioning in ways which have brought on the irritation. So that's one thing that you could modify separate from the running that would actually make the running non-painful. Yeah. But yeah, of course, Mike, there's many things you can modify with running. But if you modified the cadence, you would be reducing the stride length. And if you reduce the stride length, you would be most likely reducing the hip extension, and therefore you might put it into a non-painful range. So that would likely work.
Cool. Got another one about can we do PNF? I guess for where it feels like a stretch rather than a squash.
If it's a stretch, it's a stretch. Yeah, nobody can argue with that.
Yeah, I was going to say. I think with like you said before, Dan, I think we're not going to change the morphology, but if we can affect the tissue around the hip in a positive way, then if it changes the symptoms, then why not? Yeah, it's not aggressive, is it? It's not an aggressive type of treatment. So let's have a look. What else we got? Thinking of clients with lower activity levels, possible OA, etc. Sitting posture, seating, sit to stand patterning might be worth an observation. Not sure if that's a question or a statement there, Diane. That's I think that's pretty much it, Dan. I think that's all the questions.
Dan's come out with a comment about nocebos. Could a scan possibly be a nocebo? So could the results of a scan make somebody feel worse? Yeah, not just for femoroacetabular impingement, but often scans can reduce the likelihood of a positive outcome. If people feel that there's a structural cause for their problem, they're less likely to engage in active rehab, and also more likely to focus on the pain elements as well. And yeah, so it definitely can, and that's another reason not to jump in and get scans straight away, is that they can be taken out of context. Yeah,
good, brilliant.
Tell you what wasn't a secret, Mike, is that picture of those giant pincers in your anatomy lesson.
Did you like that?
Wire cutters. I've got a pair of those in my garage.
I was thinking, how can I get a mental image in people's minds? There you go. Yeah. You'll never forget that now. I've actually got a real human pelvis.
Oh yeah.
Right, and there is a huge difference in the acetabulum on the left, really deep on that side, compared to this side, quite shallow on the right. So you can see even the morphology from side to side. I know we've talked about this before, but it can be very different, and maybe one of the reasons why someone just feels a bit more of a pinch on one side than the other. And like you said, that the guy who just went to 90 degrees, it's just the way you are sometimes. It's and like Dan said, if you get imaging and it can be seen in a negative way, but actually it's just blame your parents. That's there's not a lot you can do about your structure.
yeah, that's right. Cool.
I think that's it, Dan. I think we're good. Yeah. Thanks very much for the exercises and the assessment. Really good, especially for the online aspect of it as well, especially during these times. How do we assess a hip online? So that was really, really useful. Thank you for that.
Thanks, Mike. For those people that want more, I'm on talking about the difference between how to assess the difference between osteoarthritic hips and gluteal tendinopathy tomorrow at 8 on the Instagram at Therapy Expo. Therapy Expo's Instagram, live at 8 o'clock. Osteoarthritis and gluteal tendinopathy.
Brilliant. Great. Thanks, Dan. And thanks everyone for joining in.
We'll put this on the Physio channel.
Yeah, great. Yeah, brilliant. Thanks, everyone.
Guys, see ya. Bye.
Bye.